Hi, my name is Jennifer Sasenti, and I am an acute care nurse practitioner student at the University of South Florida. And today I'm going to present a case study on acute pericarditis. This case occurred on October 21st, 2016. The patient's name has been abbreviated to protect his identity. His name is Kojo. He is a 33-year-old Caucasian male who presented to the ED on the 21st with a chief complaint of 8 out of 10 retrosternal chest pain and feelings of palpitations that began 4 hours ago. His chest pain radiated to the left shoulder and neck. He described the pain as a sharp pain that was worse with inspiration and was relieved by sitting forward. He stated that he had a low-grade fever at home of 99.9 to 100.8 for the last 2 days. He denies any cough, but did state he was short of breath. And the shortness of breath was due to pain with inspiration. He took an over-the-counter baby aspirin about 1 hour prior to arriving to the ED, and also took ibuprofen 2 hours prior to arriving to the ED, with neither providing any relief of his chest pain. The patient claimed to have no medical history, although he stated he was diagnosed 1 month ago with infectious mononucleosis. He was prescribed no medications. He had no allergies to medications, latex, over-the-counter drugs, or any environmental stimuli. His surgical history included an appendectomy and tonsillectomy during childhood. His vaccinations were up to date. His social history was positive for daily marijuana use and social alcohol use, mainly on the weekends. He denied ever using tobacco. He denies any other recreational drug use, and he was currently unemployed at that time. Mom is alive. She's 57 years old, but she does have a history of heart disease, hypertension. She had 2 cardiac stents placed post a myocardial infarction, and she suffers from hyperlipidemia. Dad is also alive at 62 years old. He has a history of type 2 diabetes, hypertension, and hyperlipidemia. His vital signs when he arrived showed a heart rate of 118. His respirations were 18. His blood pressure was elevated at 158/62. His temp, an oral temp was taken, and it was 99.9 degrees Fahrenheit. He was complaining at that time of 7 out of 10 chest pain. He is 6 foot tall, about 82 kilos, and his BMI was 30%. Constitutional evaluation showed an ill-appearing 33-year-old male that was in acute distress. He was afebrile with complaints of malaise. Head was normocephalic, atraumatic. His pharynx were without exudate. His neck was supple without thyromegaly, and his trachea was midline. He did have posterior and anterior cervical lymphadenopathy, which he states has been present for about the past 3 to 4 weeks since he's been diagnosed with infectious mononucleosis. He had no use of accessory muscles, equal chest expansion, but he was unable to fully expand his lungs due to pain on inspiration. He was dyspneic on exertion. He had decreased fremitus with rales noted over the lower left lobe, but otherwise the remaining lobes were clear. He had no jugular venous distension. There was no edema noted. He had no carotid murmurs or bruits. S1 and S2 were regular, and the rate and rhythm were regular. There was no murmurs, bruits, or heaves noted. He had good capillary refill. There was no pallor noted to the conjunctiva or the mucous membranes. But he did have a pronounced pericardial friction rub that was heard over the left lower sternal edge of the apex. His abdomen exam was essentially negative. He had no hepatomegaly or splenomegaly. His abdomen was soft, non-distended, and non-tender. It was tympanic on percussion. Bowel sounds were heard in all 4 quadrants, and he was passing flatulence. GU exam was negative. He had no complaints of dysuria or CVA tenderness. He denied hematuria or any penile discharge. Uh, he denies any changes in his bowel movement, denies any gastrointestinal bleeding. He did say that he did have nausea for the past 2 days and has vomited 2 times today. Musculoskeletal exam was negative. He had 5 out of 5 strength noted in all 4 extremities, full range of motion, and there was no joint pain noted upon palpation. He was alert, oriented ×4, and had no focal deficits on exam. There was no rashes noted, no lesions, no open wounds noted on the skin exam. His skin color is normal for his ethnicity. Skin was warm and dry, and there was no cyanosis. So initially, when the patient presents with chest pain, the first thing we do is a 12-lead EKG. His 12-lead EKG showed global ST elevation, all leads, with a smiley face appearance and decreased PR interval. That, in conjunction with the physical exam findings of retrosternal pain that was improved when sitting forward, and also the pericardial friction rub, led us to our primary diagnosis of acute pericarditis. Therefore, the plan was now to order labs and diagnostic studies that will prove this diagnosis and also help us determine the etiology of his pericarditis. We ordered a CBC. The CBC showed some leukocytosis with a WBC of 11.2. At that time, we also ordered a lactate. His lactate level was normal. We therefore were not leaning toward a bacterial etiology, but we still ordered blood cultures and they were pending. We ordered an ESR and a CRP. Both were markedly elevated, which confirmed our diagnosis of pericarditis. His BNP was normal, his electrolytes were normal, his creatinine was normal, and his BUN was normal, which a normal BUN would essentially rule out a uremic cause for his pericarditis. His troponin was elevated at 1.8, which also can occur with acute pericarditis. We ordered a mono spot test, which was positive. And we also ordered an ANA and HIV. The mono spot test being positive led us to make the most likely differential diagnosis for as to why he had acute pericarditis. Having a positive mono led us to believe that he had a viral acute pericarditis due to the Epstein-Barr virus. But we still went ahead and ordered the ANA to rule out rheumatoid arthritis or systemic lupus as a potential cause. And we went ahead and ordered HIV as well, just to rule out HIV also as a potential cause for the pericarditis. We ordered an echocardiogram. The echocardiogram showed a mild pericardial effusion. He did have a normal ejection fraction and normal valve motion. We also ordered a chest x-ray, which showed a small left pleural effusion. We also wanted to order a CT chest to see if we can see any changes with the pericardium, whether the pericardium was thickened or anything for that matter, but we were unable to order the CT chest because our CT machine had stopped functioning. So because it wasn't operating correctly, he was unable to have the CT chest at that time, but it was ordered to be completed once he was admitted as an inpatient. So with all the labs and the diagnostic studies and the physical examination and the history, we were pretty confident that this patient had a viral acute pericarditis due to the Epstein-Barr virus. Pathophysiology of acute pericarditis, in most cases, is the pericardium is acutely inflamed and has an infiltration of polymorphonuclear leukocytes and pericardial vascularization. Often the pericardium manifests as a fibrinous reaction with exudates and adhesions. Viral infection is the most common cause of acute pericarditis. The disease is usually a short, self-limiting disease that lasts about 1 to 3 weeks. There are many causative viruses that can lead to acute pericarditis, and as you can see, Epstein-Barr virus is one. This next slide is just some images of acute pericarditis. The first image is an image of an actual heart that shows some fibrotic changes to the pericardium and also shows some inflammatory changes to the pericardium as well. The next slide is just an echocardiogram that shows the pericardial effusion and shows a small left pleural effusion, which is pretty similar to what the patient's echocardiogram showed. The next one is just an EKG, a pretty textbook EKG of acute pericarditis that shows global ST changes in every lead, and each of those has that smiley face appearance, which is also pretty textbook of acute pericarditis. So our treatment and plan for this patient was obviously applying oxygen if needed to keep his oxygen saturations greater than 92%. We kept him on a continuous cardiac monitor to be aware to monitor for any arrhythmias, because those are potential complications with acute pericarditis. We started him on high-dose NSAID therapy. Ibuprofen 1,800 milligrams per day is ordered. According to guidelines, this is the first-line therapy for viral pericarditis. This high-dose NSAID therapy should last 7 to 14 days and should be maintained until normalization of CRP. Once his CRP is normalized, the NSAID therapy can be tapered down over the period of 1 or 2 weeks, and this is to prevent reoccurrence of pericarditis. We also gave him Toradol IV, 60 milligrams in the ED, and then ordered 15 to 30 milligrams of Toradol IV to be given every 6 hours as needed for pain. Maximum dose of Toradol was 120 milligrams per day, and it's not to be exceeded for any longer than 5 days. We also put him on Protonics for PPI prophylaxis. We gave him Norco 5 milligrams every 4 hours as needed for pain. We got orders to admit him to PCU, where he could be monitored closely for tamponade. We consulted cardiology and the hospitalists. We ordered CBC, BNP, MAG, and CRPs daily. ECGs and CO troponins were ordered and should be trended. We placed him on a clear liquid diet until he was evaluated by cardiology and they could advance diet as tolerated. He's also going to need serial echocardiograms to monitor the pericardial fluid. And then we're going to await the blood cultures and the ANA and the HIV level and HIV testing because if any of those come back positive, it may affect, the treatment plan and change our course of treatment. We decided not to begin him on corticosteroid therapy due to current guidelines. Current guidelines state that corticosteroid therapy should not be administered when viral pericarditis is evident. The fact being that corticosteroid therapy can actually enhance viral replication and therefore make the situation worse. So because of this, we decided to not start him on corticosteroid therapy and let that decision be made by the cardiologist. And that is the end of my presentation. I use the European Society of Cardiology guidelines for the diagnosis and management of pericardial diseases, and also use practice consideration for adult gerontology acute care nurse practitioners as references for this presentation.